Let me welcome you all to our webinar today on clinical challenges in multiple pregnancy. And the webinar is actually hosted and run by the Egyptian Representative Committee of the Royal College of Obstetricians and Gynecologists. And we have our wonderful friends and colleagues here sharing with us. We have Professor Elizabeth Louis from Belgium, Professor Asma Khalil from the UK, and Professor Hatem Musa, which I'm going to introduce each one individually at the time of their lectures. And I will hand the mic now to our colleague, Professor Yasser Abu Talib, the chairman of the Egyptian Representative Committee of the Royal College, to welcome you all and give the introduction to the webinar. Professor Yasser.
Okay, so hi all, how are you doing? It's actually my pleasure to meet you again. As you know, that every 2 months we used to hold this webinar, a sort of social relation between all of us. That's number one, under umbrella of scientific programs. So we are very happy to meet. Today we are going to discuss a very important topic regarding to fetal medicine, and it gives me a great pleasure to be with a group of my closest friend to my heart and close friend to everyone. Professor Dr. Asma Khalil. She's a very good, kind friend of us. She is a professor back in England and UK, and she used to be supportive for our activity all the time. As well, it gives me a great pleasure to introduce Professor Dr. Hatem, who is the lead of our activity in Egypt, between Egypt and England as well, and is going to introduce a very nice talk as well. Ms. Elizabeth, who is a professor in that field. So I'm very happy to welcome you all and thank you very much in the name of the Egyptian Representative Committee of the Royal College to participate in such a wonderful activity that we are going to have a sort of social relation everywhere and scientific relations as well. Let me just to announce a very good news that we are preparing for our 13th International Congress in Egypt, the Egyptian Representative Committee and the ERC-RCOG Congress in Egypt, which will be held during 23rd and the 25th of September. However, the most important point that 20 after 26, 27, starting 27th, 28th, and 29th as well, we are arranging a very important training program in the field of fetal medicine. We are going to start with invasive procedure the first day, which is 27th, and after that, it will be 2 days afterwards for advanced training program for fetal medicine. However, as a flavor or a new flavor for this course, we are going to add Professor Oscar, who will attend our Congress and meeting at the same time, and as well who will be the first one to introduce teaching modality of the fetal echo, which will be taught, which will be taught completely during this course as well. This is the first time to introduce that, and we hope to register yourself as early as possible in this course, because it will be a fruitful course, especially if it's if we are going to add fetal echo training program. As well, one of the most recent courses that we are going to introduce it, the AI, artificial intelligence course, which we are going to hold it online. It's a very cheap one. However, it's of a great scientific value for everyone in the field of obs and gynae, how to use AI in the field of obstetric and gynecology and fertility as well. And it will be very supportive. It's mainly between 4 and 6 hours online course. And we are supporting the course from the ERC committee, because it's very important to spread this idea for everyone. It will be 12th of September. So if you are interested, just register yourself, and I am recommending both of them, the fetal medicine course and the artificial intelligence course for everyone. Don't waste it, because it's a very good chance to gain lots of information and new things. In addition, we have lots of courses, total laparoscopic hysterectomy course, CTG course, robust course, and for other franchised course as basic practical skills for the Royal College of Obstetrics and Gynecology. Actually, I'm happy to be with all of you, and I wish you all the best, and waiting for you. These are our friends, collection of consultants and professionals in the field of fetal medicine from everywhere, from England, lots of them coming from England. Thanks very much to allow that chance to share our activity. Professor Sharif, who is responsible for MENA region activity, Professor Karam, Professor Al Hayek, Professor Bulgar, lots, Hatem, and Asma as well on top. So as you see that it will be a huge course for fetal medicine, plus Professor Oscar for fetal echo. He will be there. Thank you very much. And I'm introducing again Professor Ahmed Zakaria Sheikha. Thank you, Ahmed, for your kind support and for your leading for this wonderful meeting. Thank you very much, and have a nice day. Looking forward to see all of you. Have a nice day. Bye-bye.
Okay, thank you, Yasser, and thank you for the introduction. And let's start with the webinar. I'm now introducing our first speaker, Professor Asma Khalil. Asma is actually a professor of fetal medicine in St. George's Hospital in the University of London, and she's the director of the fetal medicine unit in Liverpool Women's Hospital. Of course, we all know that Asma holds the position of being the vice president of the Royal College of Obstetricians and Gynecologists. Asma will actually start by a very clinical important topic, which is the controversies in preterm labor in twins. And I hand it over to you, Asma.
Thank you very much, Ahmed, for this very kind introduction, and thank you for invitation. It's a real honor, and honestly, it's a real pleasure to be here with you and to join this very important educational webinar, and hopefully have a great discussion together at the end. So I'm going to talk to you about preterm births in twin pregnancies. So currently I work in the UK, and why this webinar is dedicated or focusing on twin pregnancies. So in the UK, if you look at the incidence of twins, is about less than 2%. It's in fact about 1.5, 1.6% of the total births. But when it comes to the representation of stillbirths, it contributes to 6% of stillbirths, 10% of neonatal deaths, and the risk of cerebral palsy is 6 times higher in twins compared to singletons. So you can see clearly from these figures that multiple pregnancy contribute disproportionately to stillbirths, neonatal deaths, and cerebral palsy. In the UK, there is an important national body called Embrace, and they publish confidential inquiries into stillbirths and neonatal deaths. And a few years ago, they published this report that focuses also that presents confidential inquiries into stillbirths and neonatal deaths in twin pregnancies. And the main finding, or the headline, that in about half of these cases, they reviewed the care of about 50 twin pregnancies that resulted into stillbirths or neonatal deaths, and they found in about half of these cases the care was poor, and if the care had been better, it may have prevented the baby from dying. So why I'm telling you about this in a talk on preterm births in twins? Because in this report, 14 out of the 19 pregnancies where the care was suboptimal, they were at the extreme preterm gestation between 22 and 26 weeks. And we know that at this gestational age window, certainly the care is variable. There's very little evidence to guide our practice. The other thing that they do in this report is they review the cases and they make some recommendation based on the findings of their reviewing these cases. And certainly one relevant recommendation is that if you have a twin pregnancy that's extreme preterm birth, you should delay the birth of the second twin following the delivery of the first twin. So do not automatically augment the delivery of the second twin in the absence of uterine contractions or vaginal bleeding or evidence of infection, because prolonging the pregnancy will improve the outcome of this twin. Another area which is really tend to be quite controversial, limited evidence, people really struggle to know how to best counsel the parents or manage these pregnancies, is twin pregnancies where there is premature rupture of membrane before 26 weeks. And this paper, we published it last year, where we looked at the outcomes in using the data that's published in the literature of these cases, twin pregnancies with PROM before 26 weeks. And I'm just going to summarize sort of the key findings in 2 slides. If you look at the obstetric outcomes, it's important to realize that actually in about 20%, 1 in 5, there was spontaneous miscarriage or fetal demise. The live birth was about 70%. And in about half or more than half, this case is delivered by cesarean section. In about a third, the woman developed chorioamnionitis, and in about a third, the mother developed one of this composite maternal morbidity, defined, as you can see in the slide, ICU admission, sepsis, acute renal failure, severe postpartum hemorrhage, blood transfusion, endometritis, hysterectomy, DVT, and readmission. So important adverse maternal outcomes. What about the neonatal outcomes? What we found is that the composite neonatal morbidity, as you can see defined in the slide, occurred in more than half of the cases, whether grade 3 or 4 intraventricular hemorrhage or bronchopulmonary dysplasia, pulmonary hyperplasia, and so on. And in about 1 in 4, 27%, there was neonatal mortality. And you can see other also adverse neonatal outcomes. But the reason why I chose this topic is because actually, yes, there are many complications that can affect twin pregnancies, but certainly preterm birth remains to be the leading cause of perinatal mortality and morbidity. And that's the case whether twins or singletons. So how common is this? Well, if you see in singleton, the incidence of preterm birth before 34 weeks is about 1%, and that's a spontaneous preterm birth. For twins, it's about 15%, and triplet about 30%. So of course, the risk is higher. And do we have any marker that help us to identify this pregnancy? Where we know the shorter the cervix, the higher the risk of preterm birth, and that's the case, I guess, in singleton or twins. If you look at the data, I showed you the data from the United Kingdom where I work, but the data from the United States, again, you see sort of similar. Of course, preterm birth is higher in twins, about 10 times higher in twins compared to singleton, and triplet more than 60%, preterm birth less than 34 weeks, and quadruplets, again, more than 3/4 of them will deliver before 34 weeks. Doesn't matter whether the chronicity and amnionicity. So is the risk of preterm birth higher in monochorionic compared to dichorionic pregnancies? And the answer is yes. If you look at preterm birth less than 32 weeks, monochorionic is double, 14% compared to 7%, monoamniotic 27%. And in this paper, we published it again a few years ago, data from nearly 30,000 twin pregnancies. We found the same. So chorionicity, monochorionic twin pregnancies associated with higher risk. So here, if you have odds ratio of 1.5, means about 50% higher incidence or risk of preterm birth in monochorionic twins compared to dichorionic twins. And I'm going to focus the rest of my talk about the screening and prevention of preterm birth in twins. I'm going to focus on where is the recent evidence, what's the most recent recommendation, and where is this area where there is still controversies. Whenever you talk about a preterm birth, there is spontaneous and iatrogenic preterm birth, and this talk is mainly dedicated really to spontaneous preterm birth. And whenever you talk about screening, you need to talk about whether you screen asymptomatic women, so you're screening all the population, you offer it to all twin pregnancies, or symptomatic women, so women who actually present with abdominal pain, or you say they may be threatened preterm birth. In asymptomatic women, the best screening marker that we have in twin pregnancies is the cervical length assessment, single measurement, 20 to 24 weeks, and is a good predictor for preterm birth with various cutoffs, so 28, 32, 34 weeks. And the reason why I'm saying this, because of this meta-analysis, the positive likelihood ratio, you can see, is around 10, which indicates it's a good screening marker. And therefore, when we wrote the ISWA guideline, when we wrote the FIGO guideline, we did recommend that all twin pregnancies should have cervical length assessment in the second trimester, so between 20 and 24 weeks, and the cutoff is 25 millimeter. But is this recommendation consistent across all professional bodies? Well, in this slide, I put a list of the professional bodies or professional societies that publish relevant guidelines, whether the American, the SMF, whether the French, ISWOG, FIGO, or NICE in the UK, or the German or the Canadian. And you can see that majority actually do recommend cervical length assessment for screening, but actually not all of them. So certainly the French didn't, and the NICE until last year, they did not recommend cervical length assessment. The NICE guideline updated their guidance on twin pregnancies, was published in April 2024. And in this updated version, they did actually recommend cervical length assessment between 16 and 20 weeks. Despite the fact when we were updating the previous version that was published in September 2009, we did not recommend screening, despite the fact the evidence is clear. Cervical length was the best screening, but we did not have an effective intervention. And if you don't have effective intervention, NICE has this approach of not recommending screening. Okay, well, obviously the evidence changed, and there is evidence supporting to giving progesterone to women with a short cervix, and therefore, based on that, NICE changed the recommendation and recommended a single cervical length assessment between 16 and 20 weeks, with a cutoff of 25 millimeter. And if the cervix is 25 millimeter or shorter, you offer progesterone. That's a natural progesterone, the cyclogest in the UK, not the injections. Okay, so back again, this is a list of the professional societies or the guidelines. You see sort of what gestational age. I showed you earlier, 2024. I showed you that NICE said do it from 16 to 20 weeks. And you can see there is a degree of variation in terms of what gestational age window we should offer cervical length assessment. But you can see they are around the second trimester, around 20 weeks. Should we do it transabdominal or transvaginal? And certainly, transvaginal assessment of cervical length is more accurate, but certainly we also know that not all women would want to have a transvaginal assessment. So you can see there's also variation. Some guidelines that say transvaginal, some that say transabdominal, and if you think the cervix is short transabdominally, you proceed with transvaginal scan. But we also know that actually accurate assessment of the cervical length using transabdominal ultrasound scan is not that great. Okay, what about the cutoff? And I did mention 25 millimeters. So the guideline that did actually recommend the service-specific cutoff, they did recommend 25 millimeter. A few months ago, we published this TWINS project, which is a consensus on screening and management of preterm birth in twin pregnancies. And certainly the consensus with the fact that, yes, we should be offering cervical length at 18 to 23 weeks, transvaginal approach, and the cutoff is 25 millimeter. But things are never really black and white in medicine. Because what we know from the data is that actually cervical length varies with gestational age. And the performance or the accuracy of the cervical length for preterm birth also changes with gestational age and also changes with the preterm birth cutoff, whether you do of 28 weeks or 32 weeks. So one size doesn't fit all. But the truth is that sometimes when you write guidelines, you have to be pragmatic for easy implementation, so 25 millimeter. I did say that most of the guidelines recommend single cervical length assessment. What about longitudinal? Should we be longitudinal assessment of the cervical length? And this is a Canadian study that identified 4 patterns of cervical length changes. And you can see this pattern are important because they have different risk of preterm birth with the various cutoff, as you can see here on the graph on the right-hand side. Less than 36, less than 34, less than 32. And you see here the green, which is stable all the way across the gestational age, the red, which is early rapid shortening, the yellow, which is late shortening, and the blue, which is early shortening, and then plateau. And you can see here that the risk of preterm birth varies according to these 4 patterns. And I was fortunate to lead on the ERC-RCOG guideline on twin pregnancies, and we updated this guidance. We published in January this year. And according to this, we did recommend that actually all twin pregnancies should have transvaginal ultrasound assessment with cervical lens between 18 and 24 weeks with a cutoff of 25 millimeter. But we also did say that if you take into account this longitudinal changes, that if a twin pregnancy with an additional risk factor, so for example, she had a previous preterm birth, is that we should be also offering additional ultrasound scan before 24 weeks because of this progressive or changes in the cervical lens assessment. That's a change. We did not include that in the previous guideline. So that's what we included in the ERC-RCOG guideline. That's the most recent version. Okay, so you think that this is clear, is it? There's plenty of evidence. Most of the guidelines recommend it until this paper was published this year, a few months ago. And this paper included data, so IPT, so including data from a large number of studies, and actually questioned the single cutoff value of cervical lens assessment to differentiate between the low risk and high risk for preterm birth. They found it's actually a continuous variable. So for each 1 millimeter increase in cervical lens, it was associated with 7% reduction in the risk of spontaneous preterm birth before 34 weeks. And therefore, according to the study, they strongly recommend that we should not be using single cutoff for cervical lens assessment. So that's in asymptomatic women. What about in symptomatic women? So the woman who come actually and say with abdominal pain, you think that maybe risk of threatened preterm birth. Is cervical lens is the best screening tool for this woman? And the answer is no. It's actually a poor predictor for spontaneous preterm birth. And why I'm saying this, because you remember I showed you the meta-analysis before, and I said if it's positive likelihood ratio of about 10, that was indicating good screening test, while here is about 1 to 2, so very poor predictor. So it's not recommended. What about the biochemical markers, things like fibronectin, for example? And this is, again, a paper that we published a few years ago, more than 6,000 twin pregnancies, where you actually can see this is a list of the promising biochemical markers. On top of the list, of course, the fetal fibronectin, but you can see there's other markers as well, but importantly that they are associated with increased risk of preterm birth. None of them is a good predictor on their own. So they need to be integrated into a model that has several variables to be able to actually predict the risk or screen for preterm birth in this women. So that's about screening. What about in prevention? And for prevention, again, we're focusing on spontaneous preterm birth. And prevention, either you give it to everyone or you give it to the high-risk group. So what about the bed rest? Is it useful to reduce the risk of spontaneous preterm birth in twin pregnancies? And the answer is no. This Cochrane review had clear conclusion that whether strict or partial bed rest, whether in a hospital or at home, did not report any benefit in reducing the risk of spontaneous preterm birth in twin pregnancies. What about oral beta mimetics? Is it useful? And again, another Cochrane review to say actually it's not. So whether any of this relaxants, beta mimetics, none of them was actually effective in reducing the risk of spontaneous preterm birth. What about progesterone? So if you look at the data on progesterone, either you give it to everybody, so unselected population, or you give it to a group of twin pregnancies that are particularly at high risk of preterm birth, like having short cervix, for example. And again, this meta-analysis giving progesterone to all twin pregnancies with the aim of reducing the risk of spontaneous preterm birth is not beneficial, no favorable effect. In fact, it's even worse because it was actually increases the risk of some adverse outcomes like perinatal deaths, respiratory distress syndrome, or composite adverse outcomes. And where is the data to support that? This is a relative risk. This is a 95% confidence interval. If the 95% confidence interval include 1, means it's statistically significant. And you see, so 1.6 means 60% higher risk of perinatal deaths. What about twin pregnancies with a short cervix? Is it actually useful to give progesterone? And this is, again, IPT meta-analysis led by Professor Romero. where actually this is something called the forest plots. This is how we report meta-analysis. Each line is a trial, and the diamond at the bottom, the pooled or the combined results or the data from all of these trials together. And here, relative risk of 0.69 means 0.7, about 30% reduction in the risk of spontaneous preterm birth. So based on that, giving vaginal progesterone to women who are twin pregnancies with short cervix is beneficial in reducing the risk of preterm birth, actually with various cutoffs, and also reduce the risk of neonatal mortality and morbidity. And also the IBD meta-analysis demonstrated that there was no harmful effect on the childhood neurodevelopment. Perfect. However, a few years ago, this trial by Rifai, which is actually was the largest trial, you can see the size of the square is related to the size of the trial. So it was the largest trial, actually was retracted, and therefore questioned the results of this meta-analysis. So in response to that, the authors, what they do is that they removed this trial from the analysis, updated the search, included the recent trials, and they did this repeat analysis, and they found actually similar and interestingly very similar results. Still, progesterone was beneficial in reducing the risk of spontaneous preterm birth in twin pregnancies. 0.6 means 40% reduction, significant. So still, the conclusion stands that actually progesterone is useful in reducing the risk of spontaneous preterm birth in women with short cervix. What's the most recent? Very, very recent, literally a few weeks ago, this is the meta-analysis had to be updated again because this trial was retracted, and therefore, of course, questioned the results of the meta-analysis. So again, the author did the same, removed the trial, updated the literature, and the results is still the same. So again, the relative risk 0.6, so that means 40% reduction in the risk of spontaneous preterm birth, as well as neonatal mortality and morbidity. Okay, so, and therefore, that's why I told you that actually NICE changed it. So now they recommend cervical length assessment, and they recommend giving progesterone to those who have short cervix. What about the other professional societies? So again, this is a list of the guideline, and you can see some of them do recommend progesterone, but some don't. So it is actually still controversial. And I did tell you about the updated NICE guideline in April last year, where they actually now recommending giving progesterone to twin pregnancies with short cervix. And again, in the twins project, there was consensus to actually offer vaginal progesterone to twin pregnancies with short cervix. And again, in the most recent update of the ISWA guideline on twin pregnancies, we did recommend giving progesterone, vaginal progesterone to those with short cervix, but we also wanted to make a clear recommendation that do not give prophylactic or don't give routinely progesterone to all twin pregnancies or unselected twin pregnancies. Moving on to the cervical cerclage, again, it's quite a controversial topic in twin pregnancies. And because this meta-analysis, which is in twin pregnancies with short cervix, you can see here that they actually, remember the first plot, you remember the different trials, and you pool the results in this diamond shape, and you can see the diamond shape crosses the line of 1, which is a no difference, no statistically significant. So it's not actually beneficial based on that, and therefore, traditionally or conventionally, people don't want to put cerclage in twin pregnancies. However, what about the pregnancies that present in the second trimester with cervical dilatation? More than 1 centimeter. And we know that these pregnancies, whether singleton or twins, they do have poor outcomes. So the risk of preterm birth, whether less than 32 weeks or less than 28 weeks, is very high, 90%. 90% will deliver before 28 weeks. And in fact, the perinatal mortality is very high, 50% in singleton, 60% in twins. So if there is a role for emergency cerclage to these women who present in the second trimester with a dilated cervix, well, this randomized controlled trial that was published in the American Journal, very small. So only 17 women in the cerclage, 13 women expectant arm. They included twin pregnancies presenting with cervical dilatation between 1 and 4 centimeters before 24 weeks, so in the second trimester. And they randomized these women to either expectant management or emergency cerclage, or they call it physical exam, indicate cerclage in the United States. And also this group had antibiotics and also had indomethacin. And the trial, as I said, very small, and because this trial was stopped early. after the midterm analysis because the results were so significant that it was unethical to continue to randomize patients to the expectant management group. So what were the results? Well, if you look at the preterm births with various cutoff, significantly lower in the group that had the cerclage. If you remember, I told you this group of women, 90% of them will deliver before 28 weeks. Expectant arm, 84%, so nearly 90%. And in the cerclage, 40%. So relative risk 0.49, about 50% reduction in the risk of preterm birth before 28 weeks. Some people would say, so what? We don't care about just the preterm birth. What we care about actually the perinatal mortality. And if you look at the perinatal mortality here, was 70, nearly 80% in the expectant arm, about 20% in the cerclage arm, 0.2, 80% reduction in the risk of perinatal mortality in the group that had the cerclage. So really based on this, and again, if you go back to the professional societies, the professional society, almost all of them, no, they don't recommend cerclage. The ERC-RCOG and FIGO, we did actually acknowledge that the fact that there is evidence supporting emergency cerclage in twin pregnancies with dilated cervix in the second trimester. So what's the latest evidence on the cervical cerclage in twin pregnancies? And the reason we published this meta-analysis is because we wanted to look at, of course, the role of emergency cerclage, but also not just in dilated cervix, but also in very short cervix. Because some women, you give them progesterone, and despite that, still the cervix is very, very short. Is it not open, but very short? Is there a role for the cerclage? And if you look at this, when we did this meta-analysis, this were the top three was actually the mouse control trials. The bottom were the observational studies. And if you put all of them together, 0.73, so that means about 30% reduction in preterm birth less than 34 weeks. But if you look at the RCTs only, there was no significant, but there's only small, 38, 36 in each arm. And if you look at the observational studies, much more, about 500 in this arm, about 375 in the other arm, significant. So observational studies significant, all the meta-analysis significant, RCTs themselves, small number, so not significant. Also, we looked at and in this group, we included both the one with dilated cervix, but also very short cervix, less than 15 millimeter. And if you look at the perinatal loss or the composite adverse outcomes, it is significantly lower, about 60% or about 30%. And if you look at the twins project, there was consensus that in women with dilated cervix, we should be offering the emergency cerclage. And what about the women with short cervix? There wasn't really consensus. So about more than 60% of people said yes, if the cervix is less than 10 millimeter, another 60% less than 5 millimeter, but there wasn't majority, did not reach the cutoff of about 70%. So short cervix, a bit controversial, but actually dilated cervix, the evidence was clear. Okay, some technical things from sort of the clinical practice. What's the maximum cervical dilatation? Do I put cerclage if the woman is fully dilated, 8 centimeter, bulging membrane prolapse in the vagina? And again, the evidence is not really robust, but certainly there was consensus about 5 centimeter maximum cervical dilatation. And even if the membrane is prolapsed in the vagina, yes, if technically feasible, it did not reach the cutoff of 70%. Again, routine antibiotics, yes, and I tend to give antibiotics myself, and also I give indomethacin before I put emergency cerclage. And what about amniocentesis? Certainly there is practice, so certainly my practice, before I put emergency cerclage, I would do amniocentesis of the presenting twin to rule out intra-amniotic inflammation. But again, there was no consensus. There was a huge variation in terms of the practice. But if you would do it, only do it for the presenting twin. You don't need to do it for both twins. So back again to this ERC-RCOG guideline, the most recent guideline related to twins as published, we did actually recommend that in twin pregnancies that are asymptomatic with dilated cervix before 24 weeks, yes, we should offer physical exam indicated cerclage with antibiotics, with tocolytics, while actually if the cervix is very short, so 15 millimeter or shorter, in this case, you may consider the cerclage, because remember the evidence was not as strong as the evidence for dilated cervix. Finally, the last part of my talk is about the pessary, and is there a role for pessary in twin pregnancies? And again, this meta-analysis and unselected, so do not give pessary to all twin pregnancies or those with short cervix. There is no favorable effect. You see here unselected twins or twins with short cervix, the preterm birth less than 34 weeks, none of them is statistically significant. The 95% confidence interval include one. What about the Stop It 2 trial? So this was the largest randomized controlled trial took part in the UK, multi-center, and this trial was negative. There was no really beneficial effect of the pessary in twins, even with those with short cervix. And also in the paper, they combined the data from this trial with the other previous trial that were published, because some previous RCTs did demonstrate or report that actually the pessary is useful in reducing the risk of spontaneous preterm birth in twin pregnancies with short cervix. But you see, this is Goya, the Spanish one, and the Dutch one were significantly beneficial, but actually some didn't. And if you pool the results of all these trials, no statistically significant difference, so not beneficial. And in fact, if you look at the list of the list of the guidelines that I showed you earlier, none of them recommend the pessary in twin pregnancies except the German one. But just maybe to highlight that Arabin pessary, Dr. Arabin, who invented the pessary, is actually a senior clinician in Germany. And again, the twins project, there was consensus that we should not be offering pessary in twin pregnancies with short cervix. So I'm going to stop here. I hope that I managed to cover sort of various aspects of screening and prevention of preterm birth in twins, and as well highlighting the area where there's still some controversies. So I'm going to stop here and happy to take any questions.
Jasma, I'm going to read out some of the questions, and because we've just collected them directly to me, so I can make it easier. So some of them already covered, but let me just highlight them again. One was asking to check the role of fetal fibronectin, one elastography role, the role of emergency cerclage or rescue cerclage, but I guess you covered that. And one was asking about endomethacin, as it's not available in Egypt. I guess endomethacin is surely available in Egypt. So mainly 3 questions: elastography role, and maybe touch again on the role of emergency cerclage or rescue cerclage, and role of fetal fibronectin.
Okay, fantastic. So the fibronectin, there are some studies that demonstrate that's associated with the risk of preterm birth in twins, but it's not a strong predictor. So, and therefore, it's not recommended by a NICE guideline, for example. I know that some people, of course, use it, and there is a Quip app, but as I said, the evidence is not really that strong for its routine use in twin pregnancies. Elastography, there are some ongoing studies about whether elastography would actually improve the prediction for preterm birth in twin pregnancies, which I think looks promising. But just doing cervical length assessment as well, that's what the current recommendation is, that we should be doing routine cervical length assessment at around 20 weeks to predict the risk or screen for preterm birth in twins with a cutoff of 25 millimeters. The cerclage, I think I did sort of share with you the evidence on emergency cerclage, and in my practice, I do offer emergency cerclage. But for me, the key thing is the patient selection, because I think that's the key. If someone is contracting, if someone is bleeding, if someone that you think there may be infection, absolutely not. Do not put the cerclage. But if the patient is asymptomatic and she doesn't have any evidence of infection, she's not bleeding, she's not contracting, in this case, in my practice, I'm using this of the presenting twin to rule out intraamniotic inflammation. We look at the gram stain, look at the white cell count, we look at the glucose. If you have availability, you can do the interleukin-6 in amniotic fluid. And if it's negative, I do put the cerclage, and I do give antibiotics, I do give endomethacin. And in my experience, actually, I would say more than 90% of these women continue pregnancy with good outcomes.
Let me actually commend you for a wonderful presentation, and actually touching one of the very challenging subject of actually going through the rescue cerclage, because at some point it totally came out of practice, and then again it came into the practice, and now we still all agree that cervical screening seem to be doing well in twins. We haven't sorted out everything. We haven't managed to do everything. Progesterone doesn't work. But I guess the evidence you've just highlighted that there is a role of cervical cerclage. It can help, but I surely agree with you that it's the patient selection. And again, the part of giving antibiotics, because quite a few of the preterm births are caused by group B strep infections, as the college actually highlighted in the previous guidelines, that a significant proportion of the preterms do have chorioamnitis, do have fetal infections, do have other issues. And I guess it's challenging, and I totally agree with you. It's the patient selection as well as who does the cervical crash. So if someone who's with your level of expertise in a center who knows how to handle those types of procedures, who will do it at the right time in the right patients, they will have an outcome. Thank you very much, Asma. It was a fantastic presentation, and thank you very much for your input. And we hopefully see you again in Cairo, hopefully in mid-September.
I look forward to seeing you.
Okay. All right. And let me move to our next speaker, Professor Elizabeth Louis from University of Leuven in Belgium. And the presentation is actually quite nice because it's going to address the discrepancies and discordances in the growth of twins. So it's going to address quite a few of the challenging and actually conflicting issues on twin-twin transfusion, selective IGR, and TRAP and TAPS. So the next presentation by Professor Elizabeth Louis from University of Leuven in Belgium.
So hello everyone, I'm Lisbeth Levy from Leuven in Belgium, and it's a pleasure to talk to you about the discordances that can occur in monochorionic twins, more specifically twin-twin transfusion syndrome, twin anemia polycythemia sequence, and selective fetal growth restriction. To start off with TTTS, so TTTS is a severe discordance in amniotic fluid volume between the twins. And we have strict criteria to define the amniotic fluid discordance, depending on the deepest vertical pocket. So in the donor baby or the stuck twin, there should be a deepest vertical pocket of less than 2 centimeters with a small or empty bladder, whereas the other twin, the recipient baby, has an Olympic swimming pool. And again, we have gestational age-dependent criteria for the deepest vertical pocket. And also this recipient baby has a distended bladder demonstrating polyuria. Now, it's a very obvious sonographic diagnosis, as you can see here on this clip, where the donor baby is stuck to the posterior uterine wall and the recipient baby has a very large swimming pool. It's a common complication in monochorionic twins. Unfortunately, it will occur in up to 1 in 10 monochorionic diamniotic twin pairs, and it usually occurs in the pre-viable period, typically between 16 to 26 weeks. And despite the fact that we have now fetoscopic laser surgery, it remains the main cause of death and handicap in monochorionic twin pairs. Now, for the sonographic diagnosis, I want to warn you, don't be fooled. This is an ultrasound image where you would think that this baby still has 3 centimeters deepest vertical pocket, whereas in fact, in reality, it only has 0.6 millimeters deepest pocket. And you can distinguish the deepest pocket of the donor. When the donor baby produces little urine, the amniotic fluid is more concentrated, so more echogenic, more gray. So don't be fooled by what we call the cocoon or the hamoxan. Always look very carefully that you see the intertwin membrane free floating between both babies. And as you can see here, this baby is what we call in a hammock or a cocoon, and in fact doesn't have any fluid at all. Now, the pathophysiology, although every monochorionic placenta is unique. So for TTTS, we know that typically they have several large unidirectional artery to vein communications, and they miss the bidirectional superficial artery to artery connection. And this is a typical TTTS placenta after miscarriage, where you see that there were several artery to vein connections from the donor towards the recipient, whereas there was only one unidirectional artery to vein connection from the recipient towards the donor twin, and the artery to artery connection that allows bidirectional blood flow and protects against TTTS is missing. You need to distinguish with TTTS from selective fetal growth restriction. So in selective fetal growth restriction, usually the smaller baby, because it's smaller, it produces less urine and it has less amniotic fluid than the larger twin, who's larger and produces more urine. But you can easily make the distinction because in selective fetal growth restriction, Similar to TTTS, you have a difference in size. I didn't mention that, but in TTTS, the donor is usually smaller than the recipient twin, but you can easily make the distinction with isolated selective fetal growth restriction by measuring the deepest vertical pocket. And in selective fetal growth restriction, you see that there is no severe oligopolyhydramnios present. And that's important because, as I will talk about it further on in my talk, selective fetal growth restriction is not a transfusion imbalance. It's usually due to a placenta that is not evenly divided between the twins, or placental share that is not functioning as well as the other placental share. Whereas CTTS is a transfusion imbalance. Now, because CTTS is the most important complication in monochorionic twins, and mostly because we have an effective treatment, fetoscopic laser surgery, it is recommended to screen all monochorionic diamniotic twins from 16 weeks onwards with an ultrasound scan every 2 weeks, where you look at the intertwin septum, and if you can see the intertwin septum free floating between both babies, you know, both there's amniotic fluid on both sides, and it's not a TTTS, where you in TTTS you can't see the intertwin membrane anymore because it's stuck around the donor baby, and also document that both babies have equal bladder filling. We have a large randomized controlled trial that demonstrated that fetoscopic laser surgery is superior to repetitive amnioreduction regarding the survival and long-term outcome of these infants. And so with fetoscopic laser surgery, it's minimal invasive surgery where we coagulate all the anastomosis, and we also draw a coagulation line from one edge of the placenta to the other edge, as you can see here on this postnatal injected placenta, so that both territories are completely separated and there's no intertwin blood exchange anymore. And if your laser surgery is complete, we see that the amniotic fluid discordance disappears. Now, although it's the best treatment we currently have, it's not 100% survival rate, but in 90% of cases, at least one baby survives. Severe preterm birth remains a problem, and also in 10% of infants, there are long-term neurodevelopmental issues, either because of the twin-twin transfusion syndrome or because of very preterm birth. Another transfusion imbalance that can occur in monochorionic twins is what we call twin anemia polycythemia sequence, whereas TTTS is characterized by a severe difference in amniotic fluid. TAPS is characterized by a severe difference in hemoglobin levels between the babies. And although there's still discussion about the best definition, I think you should be suspicious of TAPS whenever you have a discordance of more than 0.5 multiples of the median in middle cerebral artery peak systolic velocities, where you have decreased velocities in the polycythemic recipient and elevated velocities in the anemic donor baby. Now, middle cerebral artery discordances can occur also in the setting of selective fetal growth restriction, but you have to think of TAPS when you have this discordance together with either a congested liver, which we then call the starry sky liver, and the dark liver with the bright venules lighting up in the polycythemic recipient baby, whereas the anemic donor baby has normal liver echogenicity. Or you have what we call placental dichotomy, where you have the thin dark part of the placenta of the polycythemic recipient and the thickened white part of the anemic donor baby. So whenever you have a discordance of 0.51 with either the starry sky liver or the placental dichotomy, think of TAPS sequence. Now, TAPS is more rare than TTTS. It occurs in about 1 in 20 monochorionic diamniotic twin pairs. And also in contrast to TTTS, that is a mid-pregnancy problem, TAPS tend to occur in late pregnancy, typically in previously completely uncomplicated monochorionic twin pairs, where you will, towards the third trimester, you will see that the growth becomes progressively discordant, and also the middle cerebral artery systolic velocities become progressively discordant. Now, the pathophysiology, so the type of anastomosis are the same as in TTTS. Usually you only have unidirectional anastomosis, but what is typical in TAPS is that the anastomosis are minuscule. You really have to carefully inject your placenta to demonstrate what we call these minuscule TAPS vessels. And so that explains that TAPS through these minuscule anastomosis results from a chronic net transfer of red blood cells from the anemic donor towards the polycythemic recipient. And so that also explains the fact that in 3% of monochorionic twin pairs that underwent laser surgery for TTTS, if you coagulate all the large anastomosis, the amniotic fluid discordance will disappear. But if you're a little bit sloppy and you miss tiny vessels, and you usually miss them at the edge of the placenta, then what you will see is that although the amniotic fluid discordance disappears, usually up to 2 to 3 weeks after your procedure, what you will see is that the middle cerebral artery peak systolic velocities become discordant, and your case develops what we call a post-laser TAPS. In TAPS, it's and that is also in contrast to TTTS. In TTTS, both donor and recipient are at risk of intrauterine demise. In TAPS, it's mainly the anemic donor baby that is at risk of intrauterine demise because of severe anemia. And because TAPS can be diagnosed prenatally, and you can also do something to help the anemic donor, it's also recommended to screen for TAPS, and also from 16 weeks onwards, because TAPS can occur very early in pregnancy by measuring the middle cerebral artery peak systolic velocities every 2 weeks when you scan your monochorionic twin pairs. And as I said, TAPS can occur also at 16 weeks, and this is a case where you had the discordant middle cerebral artery peak systolic velocities and the typical placental dichotomy. Now, for completeness, we know that nature is not black and white, and you can have TTTS and TAPS together, where you have the severe amniotic fluid discordance and complying with the criteria of TTTS, but also the typical placental dichotomy. And actually, we know that 5 to 10% of TTTS cases present with a combination of TAPS and often also selective fetal growth restriction in the donor twin. But the TTTS diagnosis always overrules the TAPS diagnosis and the selective fetal growth restriction diagnosis. So we would call this a TTTS still, although TAPS and selective fetal growth restriction are also present. And that's because we know that fetoscopic laser surgery is the best treatment for TTTS. Also, if TAPS is present or selective fetal growth restriction is present. Now, in contrast also to TTTS, again, TTTS is only sonographic diagnosis. TAPS can also be a postnatal diagnosis. So we call a case a TAPS case if she didn't have previous screening for by middle cerebral artery peak systolic velocities when the hemoglobin difference at birth is more than 8 grams, and you have indication of a chronic net transfer of red blood cells, either by the difference in the reticulocyte count ratio or when you inject placentas and by the presence of only these minuscule anastomosis. So when you deliver monochorionic twins and you have a severe hemoglobin difference at birth, you have to distinguish TAPS from an acute intrapartum transfusion. And you can do that either by injecting your placenta. So if you have these huge communications, you know this must be an acute intrapartum event because TAPS has these minuscule anastomosis. But if you don't like to inject your placentas, you can flip the placenta around and look at the maternal side. And in TAPS, because TAPS is a chronic process, you have the typical placental dichotomy, whereas in acute intertwin transfusion, you don't have that placental dichotomy because of the acuteness of the event. Now, in contrast to TTTS, there is no standardized management for TAPS at present. So at the moment we individualize care. And as I said, it's mainly the donor that is at risk of intrauterine demise because of severe anemia. And also in TAPS, in contrast to other monochorionic twin pregnancies, because of the minuscule anastomosis, in the event the donor baby dies, the polycythemic recipient should not be at risk of acute exsanguination because of the smallness of the intertwin anastomosis. So the management depends on gestational age, on the severity of the donor condition, and then also whether for mid-trimester cases, whether you can offer fetoscopic laser surgery because you lack the polyhydramnios, which makes it often easy to perform fetoscopic laser surgery. So if you have a large anterior placenta in TAPS without polyhydramnios, then it can be impossible to do fetoscopic laser surgery. Now, overall, in our cases, so most of our TAPS cases, we can manage expectantly by just following the middle cerebral artery peak systolic velocities. And especially for the early second trimester cases, we see that in most cases, the TAPS disappears spontaneously, but then often the pregnancy continues with growth restriction of the ex-TAPS donor twin. And the reason why these early cases TAPS resolves often spontaneously is because of the smallness of the anastomosis. As the placenta grows rapidly during pregnancy, probably the transfusion imbalance stops because of the closure of the anastomosis. Now, if you have a severe TAPS case in mid-pregnancy, you can coagulate the anastomosis like you do for twin-twin transfusion syndrome and coagulate the tiny TAPS vessels. Less common in TAPS is the indication to perform a selective reduction. That would only be if there is a severe anomaly in one of the twins. In late cases, especially after 26 weeks, you can prolong pregnancy by giving an intrauterine transfusion to the anemic donor baby, which you often have to repeat and then combine with also exchange transfusions in recipient baby to prevent severe polycythemia. In TAPS cases where the donor has clear signs of anemia, and once 32 weeks, we would deliver them and give the babies to our neonatologist for further care. And then finally, selective fetal growth restriction in monochorionic twins. So we know monochorionic twins are monozygotic, so theoretically they have the same genetic growth potential, but even so, in 10% of monochorionic twin pairs, there's more than 10% difference in size, and that's usually because of unequal division of the placenta or isolated dysfunction of the placental part of the smaller baby. I would always recommend to eyeball, put the two abdominal circumferences next to one another to get a feeling of whether the growth is concordant or discordant. In clinical practice, the more than 20% difference in estimated fetal weight is very useful to select the cases that would need more careful follow-up for complications. And then again, the differential diagnosis should be made with TTTS and TAPS. And that also makes selective fetal growth restriction always a provisional diagnosis as long as the twins are connected to the placenta and intrauterine, and they can still develop a transfusion imbalance like TTTS and TAPS. And so you can only say this is an isolated selective fetal growth restriction once the babies are out and they didn't develop TTTS and TAPS. And as I said, TTTS always overrules, TAPS diagnosis always overrules a selective fetal growth restriction, although these complications can occur together at the same time. And so the outcome of selective fetal growth restriction is determined mainly by the umbilical artery pattern in the smaller twin. And there are three patterns. So the type 1 pattern is when the umbilical artery Doppler flow is continuously positive in the smaller twin. And fortunately, most cases with more than 20% difference in estimated fetal weight have normal positive end-diastolic flow in the umbilical cord of the smaller baby, and these have excellent outcomes. However, there can be progression, or cases can present from the beginning as what we call a type 2 case, where you have continuous absent or continuous reversed end-diastolic flow in the umbilical artery, which is the minority of cases, fortunately, with selective fetal growth restriction show this pattern. They have a 70% survival rate, and they're usually also born quite early at around 30 weeks. And then finally, the pattern unique to monochorionic twins are the type 3 cases, where you have the variable or the cyclical pattern, where in one Doppler sweep, the flow goes from positive to absent or reversed. And these have intermediate outcomes 85% survival, and still on average a very preterm birth. Now the pathophysiology, so the type 3 cases, they typically have huge anastomosis and a very elaborate, extensive intertwin blood exchange. And also they have typically one large artery to artery communication. And you, with modern ultrasound equipment, you can identify this large artery to artery connection by using color Doppler or pulse wave Doppler and demonstrating the bidirectional flow pattern. And type 3 cases, these placentas are typically very, very unevenly divided with little individual placental territory for the smaller baby. But probably thanks to the elaborate blood exchange, the smaller twin gets nutrients and oxygen from the placental share of the normally growing baby. And so typically for type 3 cases is that the growth discordance is not that large, especially regarding the unequal division of the placenta. And usually the growth discordance is around 20 to 30%. This in contrast to type 2 cases. So type 2 cases, they have very small communications, and the placenta is usually not that unevenly divided as in type 3 cases, but probably the type 2 cases are related to isolated placental dysfunction in the part of the growth restricted twin, and because there's not a lot of help from the baby on the larger share, the growth discordance is usually larger than in type 3 cases. And so usually the discordance is around 40% or even sometimes 50%. Now the advantage is, whereas type 3 cases, they can be very unpredictable. They can be in type 3 because of the large anastomosis, they can be acute intertwin transfusions, and which can explain their risk of unexpected and usually double demise. In type 2 cases, because it's more like the growth restriction and placental dysfunction in singletons. What you will see is that there is progressive deterioration, worsening of the condition of the smaller baby with development of abnormal ductus venosus, and which precedes imminent demise. So type 3 cases are very unpredictable because of the large intertwin blood exchange. Type 2 cases because of the small anastomosis, and the more likely placental dysfunction in the placental part of the smaller baby. You can predict when the smaller baby is at risk of intrauterine demise. Now for the management, so the problem, as I mentioned, is intrauterine demise of the smaller baby, and especially in type 3 cases with a large anastomosis, it's not surprising that the normally growing twin can rapidly exsanguinate into the body of the demised twin. And that's also why in selective fetal growth restriction, when there is demise, 65% present as a double demise from the start. If the larger twin survives, we also know that there's a 25% risk of severe brain damage, hypoxic ischemic brain lesions. Nevertheless, since most cases of selective fetal growth restriction are type 1, expected management is the most common management that we practice, which leads to excellent outcomes in type 1 and intermediate outcomes once the umbilical artery pattern in the smaller twin becomes abnormal. Selective reduction can especially be considered when there's imminent demise of the smaller baby or when there are discordant anomalies. There, obviously, you lose the smaller twin, so the overall survival is maximum 45%, but in 90% of cases, the larger twin survives, and also the average gestational age at birth is also around 36 weeks. Fetoscopic laser surgery, in contrast to TTTS and TAPS, will not treat the cause of the disease. You cannot redivide the placenta or improve the function, but the aim of fetoscopic laser surgery is to protect the larger twin whenever the smaller twin dies against acute exsanguination. But the problem is that if your laser is incomplete, these are often difficult procedures, that you risk losing the larger twin as well. And also, if you look at the average gestational age at birth, this still remains, on average, very preterm. So in contrast to TTTS and TAPS, fetoscopic laser surgery will not cure the disease and also does not seem to improve the outcome for the larger baby in contrast to a selective reduction. So as a take-home message, so twin-twin transfusion syndrome is characterized by severe deficit in amniotic fluid volume. It's the most severe complication that occurs in monochorionic twins and actually occurs in 1 in 10 monochorionic diamniotic twin pairs, typically in the pre-viable period. And fetoscopic laser surgery is the best treatment option, and it affects both the donor baby and the recipient twin. TAPS is a more subtle transfusion imbalance, but can cause demise of the anemic donor baby. It also tends to occur later in pregnancy than TTTS. And we don't have level 1 evidence on what is the best management, but because of the variation in presentation and gestational age, at the moment we individualize the care for TAPS cases. And selective fetal growth restriction, in contrast to TTTS and TAPS, is not due to a transfusion imbalance, but is due to mostly unequal division of the placenta or discordant placental dysfunction. And the outcome is excellent as long as the umbilical artery Doppler pattern in the smaller baby remains normal. If it becomes continuously absent or reversed, and then the outcome is less good, but the advantage is that you can follow the worsening of the condition of the smaller twin because they behave quite similar as in singleton fetal growth restriction. And in type 3 cases, these are the ones with the very unequal sharing and the large anastomosis. So although we know that most do quite well, they are at risk of acute intertwin transfusion imbalances and unexpected, usually double fetal demise. Thank you very much for your attention.
Okay, I will answer some of the questions on behalf of Professor Louis, but I have a couple of questions that came actually to Asma. So let me just highlight them and maybe Asma will answer them first and then we'll go for the questions for Louis. So one of the questions was the role of AI, and the questions for you, just a second, because we have a long list. What is the role of AI in predicting those at high risk of preterm birth, especially in twins? And what is the RCOG views on artificial uterus for very low birth weight babies? If you don't mind answering those, Asma, and then I'll go for the questions for Elizabeth.
Okay, so AI, I mean, there is obviously we are developing sort of artificial intelligence, machine learning, and prediction models to see whether they would perform better than the traditional models that we've published so far. Whether actually the AI is sort of looking at the cervical lens or cervical image, for example, and being able to give us better detection for those who will develop preterm birth. I think there's no robust evidence. But yeah, AI, potentially could be useful, but it's still, I think if anything, could be maybe still research. And certainly I'm not aware of any robust evidence using AI in the area of preterm birth in twins. The other question about artificial placenta, and certainly I think it's extremely exciting to be able to improve the survival and the outcomes of extreme preterm babies, and those obviously with severe early onset growth restriction, where invariably we need to deliver them very early, because otherwise if you don't, they will have a stillbirth or intrauterine demise. So this is a two group of babies that I think would likely to benefit from artificial placenta. The most of the research, also the data that I've seen, were mainly from the United States, from Philadelphia, and also from Gratakos, from Barcelona. I'm not aware that we have any evidence from the UK, and certainly there's no really guidelines yet. I think it's still very much research, and therefore I think it's still, I don't see that's being implemented in routine practice in the next 3 to 5 years at least. but extremely, it's a cutting edge research, extremely promising, all these very premature babies that unfortunately we cannot do much to them, or the very early severe growth restricted babies that again, you don't do much apart from delivering them or let the baby dies. I think that's something that's extremely potentially promising and hopefully would improve the perinatal mortality and morbidity.
Okay. I have a couple of actually interesting questions, and maybe we'll take the input of Hatem and Asma on that. One was, do we really think that TAPS can occur outside being a complication of laser? Can TAPS happen spontaneously?
Absolutely. I've seen many
That's
cases of TAPS, which is spontaneous, so not in the context of TTTS or laser. So it does actually occur. And I know that's been controversial in the past, but certainly I've seen many cases.
Yeah, I totally agree. And I remember being a registrar in the UK, seeing a couple of cases where the midwives left them to deliver spontaneously. And then obviously you see the acute TAPS that happens, and those with the severely polythymic and the severely anemic fetuses. Obviously this was history, but that's why we all moved to delivering the monochorionics and by elective cesareans. And the other one was actually interesting, which is there a role of corticosteroids before laser? Should you do that? Well, the optimal age of doing laser is how many weeks? What do you think?
Yeah. It depends. It depends on the gestation age that you're doing laser. So if you're doing it like 18 weeks, for example, or 20 weeks, I don't think there's any room for giving steroids. If I think the main really place that we would give steroids if we're doing laser after 23 weeks. Because, of course, there is a risk of preterm birth or rupture of membranes, and therefore I think you would give steroids. I think the benefit of steroids, things sort of go in fashion in medicine to some extent. So there was a fashion where you must give steroids. Every time the woman comes with potential return birth, you give steroids. And I think the fashion now, to some extent, is actually people are really quite cautious about giving steroids because of the fact that the potential side effects or harm. And therefore, what you need to do is to actually triage or assess what is the risk of this woman delivering in the next week, for example. And if the risk is substantial, I think in this case, we should give steroids. And if the risk is low, in this case, you don't give steroids.
Should we think of magnesium sulfate? Do we have a role in those cases?
I think the only really indication for magnesium sulfate would be if the woman is definitely going to deliver or very imminent preterm birth. And that's given sort of loading dose of 4 grams over 20 minutes. And if it's still, so the woman hasn't delivered, you could give a maintenance dose, which is 1 gram hourly. But, and therefore, let's go back to the question. If I'm doing laser 20 weeks, absolutely not. If I'm doing laser at 24 weeks, yes, I would give steroids, but I will not give routinely magnesium sulfate unless the woman already ruptured membrane and she's contracting and imminently she will deliver. In this case, we'll give magnesium sulfate for neuroprotection to reduce the risk of cerebral palsy.
I guess we covered most of the subjects here, and let me move to our colleague, Professor Hatem Musa. Professor Hatem is actually a consultant in fetal medicine and a professor in fetal medicine in Leicester University Hospital in the UK. And Hatem will address the malformations and the risk of congenital malformations in multiple pregnancies. And we hand it over to you, Hatem. Thank you very much for your input and your support.
Thank you so much, Ahmed, and for the invitation and for arranging this exciting program. I am going to try to tailor my talk as much as possible to make it more clinical and to share with everyone what we tend to do in UK. And secondly, what are the things you could apply in your clinical practice? Oops. This is not mine. Sorry. Okay, so I'm going to focus on 4 areas. The first one is counseling in multiple pregnancies with a structural malformation. What is the difference between having a singleton with multiple malformation or single malformation? And if I have a twins, what is the risk of chromosomal problem in twins, and the risk of malformation of monochorionic and the impact of twin-to-twin transfusion. And at the end, I will focus on nuchal translucency and crown rom discordance. A couple of areas are very useful to know about in clinical practice, and it's very important to bring it to your attention. So counseling in women with multiple malformation as a start. So the question at the moment is, these are cases where there is multiple malformation, it happened. We ask ourselves, is there a difference in the counseling we use? In UK or in your clinical practice, number one, we have to identify what is the current finding, what is the causes and the future investigation, and what is the course during a pregnancy. And the last question for the mom always ask is, how are you going to deliver me? Where are you going to deliver me? As a general rule in UK, if you have a surgical baby, ideally you have to deliver the baby in a surgical center. If you have a cardiac baby with major malformations that will require immediate intervention, you will need to deliver the baby in a cardiac center. But at the same time, after your initial diagnosis, the mom will ask you another few questions. What is the immediate management? What is the treatment for my baby? What is the longer-term outcome? That is the situation we always face once we pick up a malformation in one of the babies. The question here for you as audience and for me, is there a difference? If the case is twins? The answer for that is, for you as a clinician, there are 5 questions you have to answer yourself. Number one, is the type of twins could have an impact of my counseling for this patient? Is the type of malformation, is it a single malformation or there are multiple malformations? Is it affecting one baby or 2? What is the risk of genetic or chromosomal problem? And the last but the most important question, does this malformation could have an impact on the mom or baby or both? And we will look into that. For example, this is here a case. One on the left-hand side is anencephaly. The other one is multicystic dysplastic kidney. The question here, they are totally different. The one on the left side is associated with polyhydramnios, could produce preterm labor, could produce rupture membrane, and we end up by delivery around 24 weeks. The one on the right-hand side is associated with anhydramnios for the baby, and the risk of preterm labor is slightly less. Is the problem, can it have a management after, or should I do something different? This is the case here. One side completely normal baby, the second one has got exanthulus. And this case in particular, should we carry on with the pregnancy? Should we take a decision, for example, in anencephaly to do selective termination? And what is the benefit? What is the risk? For this condition in particular, this case in particular ended up with preterm labor around 26 weeks. So is there a place for selective termination? This is another case where there is intracranial brain abnormality involving both of them. So the question here in the counseling, I have a baby here, 2 instead of 1, 2, with the same problem, with a genetic problem. And there's a test came back highlighting that 2 babies have a genetic condition, hereditary motor and sensory neuropathy. So the counseling of the couple in this situation will be related to can you cope with two babies with two major problems? And that is one of the things you as a clinician should take in consideration. Here is the data, and the question for you: is the malformation more common on monochorionic twins or dichorionic twins? And irrespective of what study you read, monochorionic twins tends to have a higher rate of malformation. It is quite variable, but tends to have a higher rate compared with dichorionic twin pregnancy. And everyone will be surprised how on earth two babies will have lower rate of malformation compared with monochorionic. We will touch base on that one later on. Again, this is here the rate of congenital malformation compared singleton to twins. The commonest by far, the commonest top malformation is central nervous system, followed by cardiovascular. And you could see the odds ratio, and you could see the percentage in the population per 10,000. And this is one of the best quoted studies. So in summary, if you have twins, the risk is higher than singleton for malformation, and the risk of monochorionic is higher than dichorionic. Now, we move to the second one. What is the risk of chromosomal problem? Is it higher in monochorionic, dichorionic? What shall we do? So this is a very important study which I highlight here. So we mentioned before the monochorionic twins, we mentioned before the dichorionic, but it is very important to know if you have a single malformation, the risk of chromosomal problem is equal between the two. But if you have multiple malformation, the risk of chromosomal problem tends to be higher in dichorionic twins. And that is very critical in the counseling. Not all the same. So if you do a counseling for a woman with dichorionic twin pregnancy, baby got a brain and a cardiac malformation, the risk is quite high for expecting a chromosomal problem. So please take that in consideration when you do your counseling. Is not the same type of twins affect the risk of malformation, affect the risk of chromosomal problem. What is the commonest type? By far, again, another set here, by far, the commonest is Turner syndrome and the trisomy 21, followed by the others. But Turner syndrome has the upper hand with Down syndrome in the frequency. And that will raise another question here is, could I have a baby in monochorionic twins where one baby is completely normal and the other baby is abnormal? And the answer for that is yes. So please take that in consideration and use that in the counseling. Although it is a monochorionic twin pregnancy, but you could have difference in the pattern of chromosomal presentation. Another question we get asked about, can I use NIPT for screening if I find a malformation? The answer for that is, if you find a structural malformation in twins, NIPT is a screening test, is not a diagnostic test. But what is important is what the mom will do with the information. This is a study Asma and myself and other members in the UK done with ARIS as well, looking into the screening. The screening performance is quite high. And sometimes we have families coming to us to say, I just would like to know if my baby has got Down syndrome or not. And I'm not going to terminate the pregnancy. And in that situation, you have to make a decision and you have to decide what would you do. But generally speaking, we wouldn't normally recommend that you do that. I move on now into monochorionic twins and the risk of brain abnormalities and the impact of twin-to-twin transfusion. So why monochorionic twins have a higher rate of malformation? Simply because twin-to-twin transfusion occurs only in monochorionic twins, not in dichorionic. They are known to have higher risk even if you carry on the treatment of brain structure malformation. So this is here for laser. And you heard the story earlier on twin-to-twin affect both the recipient and the donor. The risk of brain abnormalities is 2% following laser, and it could be ischemic and it could affect the donor as well as the recipient. And the type of the lesion could be ischemic lesion, hemorrhagic lesion. Ischemic lesion for the donor, hemorrhagic lesion in the recipient. So these cases will require that you see them regularly. In UK, we see them every week after the laser to assess the brain, and we arrange MRI scan, but it all depends on the facilities available for you. And this is here multiple images highlighting the areas of ischemia, infarction, hemorrhage that occur in these cases. The second issue is the impact on twin-to-twin transfusion on the cardiac function. And this is a very important study. It's by far the highly quoted one, that the risk of cardiac malformation in twins with TTS, as you can see, is 12-fold increase if you have a TTS. How about if monochorionic twins without a TTS? The risk is still high. It's approaching 6-fold increase on structural malformation in twins. What is interesting is that risk is not related to the ventricle. That risk is related to the outflow tract. So in the recipient who receive a large amount of blood, there is right ventricular outflow tract obstruction. And in the donor who haven't got enough blood and the anemic, there is a risk of aortic valve and coart. So again, in twin-to-twin transfusion, we would recommend to assess the heart function, especially around 32 weeks. And that is something is important. Now I will move on into two areas we always see ourselves when you have screening for nuchal translucency in first trimester. You got one baby, 1.8 millimeter, you got another 5.6. The baby hasn't got a structural malformation. What is the outcome in these cases? The best evidence here coming from Professor Michaelides and his study, 6,000 twin pregnancy and more than 1,000 cases of monochorionic twins. If you compare on increased NT between DCDA and monochorionic, the difference is not that much. However, if you look on the outcome, if you have increased NT without structural malformation, the risk of fetal death under 20 weeks is approaching 20% of monochorionic, risk of laser 28%, risk of perinatal death 8.2% in monochorionic, in dichorionic 9.6%. The study highlighted very important message, which is that risk of monochorionic twins is predominantly before 20 weeks. So that is a Kaplan-Meier analysis. And you could see the difference between monochorionic and the dichorionic twins. There is a risk that something happened before 20 weeks, but it is significant on monochorionic. And if you go to the after 20 weeks, you will realize after 20 weeks, that difference started to disappear. So the general advice for you as a clinician is, obviously, if there is a difference, assess the structure of the baby. If there is no structural malformation, that group, monochorionic, at a very high risk of fetal death or requiring risk of twin-to-twin transfusion requiring a laser before 20 weeks. After 20 weeks, you could start to relax, but again, you have to take in consideration what happens after that. The second group, for a clinical point of view, is the implication of crown-rump discordance. And that is one of the things, again, as a clinician, we see. Remember the talk that Asma has given and Lisbeth? The discordance in size later on in pregnancy is 20%, but discordance is crown-rump is started from 10%. And this is here the data that from the American group looking onto dichorionic, Professor Kipros group looking into monochorionic twins. If you have a discordance 10%, the fetal loss is 22%. Under 20 weeks, 25% under 24 weeks, and the laser requirement of laser loss following a laser or without 31%. But if you look on the discordance, when it is 20%, you're approaching 60%. So that is something you have to take in consideration. For the dichorionic twins, the American group looked on nearly 1,000 cases produced. The outcome in last year in this nice paper highlighted that if you have a discordance in dichorionic twin pregnancy compared with another dichorionic without discordance, you literally 3 times increase in aneuploidy, 3 times increase in risk of malformation, 3 to 4 times increase on the risk of stillbirth and miscarriage. So if you have a discordance, please remember first trimester discordance is 10%. Discordance in size later on is 20% if you're doing your routine gross assessment. And remember that first trimester assessment of nuclear translucency and assessment of difference in size in crown-rump is very important. Finally, I'm going to conclude. There were 5 questions we tried to answer. Does the type of twins have an impact? The answer is yes. Remember, monochorionic, high risk of malformation, but lower risk of a genetic chromosomal problem compared with the dichorionic if it is multiple malformation. Type of malformation is really, really important. Is it single or multiple? Because the risk of genetic chromosomal problem is linked to that. Remember, is it lethal condition, not lethal condition? Is it 1 baby or 2 baby? That means, is it a single problem or double problems? And for families, having 2 babies with a spina bifida, 2 babies with brain major abnormalities, 2 babies wheelchair bound, sometimes very challenging, and you have to make a decision what you do here. And there are families who decide to continue with the pregnancy, and there are families who will decide not to continue with the pregnancy. The risk of genetic and the chromosomal problem is related to the twins and related to the timing of diagnosis. So please remember that one. The impact of malformation on the mom and the other baby is very critical. The classic example is the anencephaly polyhydramnios. And if you leave the pregnancy, you may end up by polyhydramnios preterm labor at 24 weeks or 28 weeks with the brain damage of the other one. If you try to interrupt the pregnancy for the anencephalic baby, there is a risk of miscarriage of both of them. So these cases will require management and the counseling by somebody have the skills in the field. And it's not the cases you deliver in your private clinic. If you are if you are looking after the woman, in reality, these cases will require management by somebody specialized in the field of fetal medicine and have the facility to deliver in a center with support by surgical team, neonatal team. Before I finish, I just would like to remind people with the course, and I put down on the left-hand side the email address if you would like to get in touch with the ERC-RCOG team in Cairo. That is the email, and it, as highlighted, it is 3 days course. Thank you for your attention.
Thank you very much, Hatem, and thank you all for all your input and your great webinar, I have to say. I have a few questions that came up, so let me just highlight them to all of you. So one is asking about the MRI for the fetal brain. Can it help really in cases of fetal demise and monochorionics or to exclude damage after TTTS? I guess on overall, we can do that. It needs specialist inputs, quite helpful in some cases, but do we really routinely need it in the context of having good ultrasound and good specialists? What do you think, Asma?
Sorry, the question about MRI.
Yeah. Do we really need to do MRIs to look for the features of brain damage in single fetal demise or post-laser therapy to make sure that it has worked or haven't done much injuries?
I mean, it depends on obviously on your number one, the facilities that you available for you. It depends on which healthcare system you work, and it also depends on your expertise in neurosonography. So if you are just doing the standard planes and not doing sort of all the targeted neurosonography according to the ESWA guideline, which you have 4 coronal planes and 3 sagittal and parasagittal planes. So if we're just doing axial views, I think yes, because MRI will be able to identify abnormalities that the ultrasound would miss. While actually, if you're doing targeted neurosonography and you're very good and maybe you don't have access to MRI, in this case, ultrasound would be enough. The other very important actually point that I think I learned from patients is the fact that would it matter? Would it change the management of the pregnancy? So for example, if the patient is going to continue the pregnancy anyway, they're not going to, because, brain abnormalities, we don't have treatment for it during the pregnancy, correct? So the only option is to stop the pregnancy. And if the patients that's not an option for her. She's going to continue the pregnancy regardless. In this case, perhaps it's not really necessary to do the MRI, and then the baby will have assessment after the baby's born. So, I think it's never black and white in medicine, and I think you need to individualize the care based on the patient, based on your practice, based on the facilities of the healthcare system where you work. I think you're mute, Ahmed.
Okay. Hatem, let me ask you a few other questions really from the audience. So some of them are asking, okay, do we have a gross discordance simply due to late implantation of one fetus in comparison to the other? Does this theory still exist? Is it really there? Do we believe that we have it? And let me ask you personally, do we really believe that we don't have equal splitting in monochorionic twins and it can happen? What's your thoughts on that?
I think you have to be very, very careful on the counseling of the group, looking on the number of discordance in size and the risk of, for example, monochorionic, the risk of TTS, the risk of genetics, the risk of chromosomal. You have to be really careful to convince a couple that it's probably this is super fecundation and implantation of another fertilized egg. So to answer your question is, I in my counseling personally, I don't go down this line. I follow the instructions that you have to assess them at a high level and follow them And is it a possibility? The answer is yes. Never say never. But the reality is, if you have a discordancy in size, there is a high risk of chromosomal problem, high risk of a structural problem. So you need somebody skilled like you, like Asma, like people who do fetal medicine, to do really early anomaly scan, assess this baby properly. But I don't go down the line of, oh, it must be another sperm and another time of fertilization. I'm not sure about Asma.
Funny enough, it's actually quite a common question that you get asked by the journalist. So there is sort of a media story every now and then they kind of say, "Oh, do you think it could be this?" And there has been some case reports actually published or reported in the literature. But I think I agree with Hatem. It's the fact that if you are a doctor that you're scanning a patient or you've got a patient with twin that's referred because of size discordance, obviously it depends on the chronicity in terms of the assessment and sort of the investigation or the test that you're going to offer. But I think it's really important that you follow up this pregnancy. And I think most women, in my experience, women are intelligent. If you actually explain to them what sort of that's been reported, it might be, but it's unlikely. And therefore, we have to monitor this pregnancy carefully in case that this is actually monoclonal twins with unequal placental sharing and the risk associated, or maybe dichroic twins where maybe one baby has a problem. So, I think yes, it's been reported, common question by journalists, but I think in clinical practice, what's common is common.
Totally agree. So we're not going to go down this line anymore. We don't talk about unequal splitting. We don't talk about late implantations. Really, it is the specialist input. Examine the baby, examine the Dopplers, examine the structure, look for what you can do. One final question, which I guess has been touched lots and lots and lots of times, the role of cell-free fetal DNA. Should we do it? Should we do it routinely?
Yes, the answer is yes, and that's up. So we updated the ESWA guideline on twins, and it was published in January this year. And actually, we do recommend now that the cell-free DNA is the most accurate test for screening for Down syndrome, for example, or common chromosome abnormalities, in particular with twins. Really, that's where the performance is almost as good as in singleton. The only thing that maybe the failure rate is slightly higher in twins. But I think if you have access, if you work in a healthcare system, you have access, I think that should be the first line. But if you work in the UK, for example, in NHS, it's not the first line. In NHS, we're still doing the combined tests as the first line. And if the patient is high risk, so the cutoff in the UK is 1/150, if it's a high risk, in this case, you be referred to fetal medicine doctor, they do routine scans, and if there's abnormality, of course, or big nuchal, in this case, you'd offer invasive testing. But if the babies are okay and there's no abnormalities, the nuchal is not increased, in this case, you could be offered an RPT or cell-free DNA.
Okay. One final question.
Just with a caveat, it does not tell you which twin is affected.
Of course, and that's why twins needs the specialist. That's why the twins need the ones who are going to look into structure. That's why the twins need the very specialist input, even to do biopsies on them. And it's not the standard procedure to do CVSs or amnios on twins. It really needs someone who really knows how to do it. So we all agree on that. And one final part, is there any role of low molecular weight heparins? One final question, which I got from the audience. Obviously, I know the answer, but I just wanted your input, guys. So role of low molecular weight heparins in TTTS, does it have any role? And obviously in discordant twins, does it have any role? What's your thought, Hatem?
I don't know. In TTTS, I first time somebody asked, could I give women low molecular weight heparin in TTS? First time I hear the question. So I don't know.
I got it from the floor, so it really impressed me. So that's why I put it on. We take this completely off the future questions, I guess, for all audience.
So the answer for that is no. The second question is about
I guess the reason why he's asking is because he sees that you have a really small twin who's struggling with blood flow and all of that. So he's just saying, would it really buy him some time? Would it give him time would it improve any chance? Well, we all agree that it doesn't. So
the answer for that is no. The second question is about the use of the low molecular weight heparin in IGR. The only thing that is coming up from the Canadian group John Kingdom, I think the paper has been accepted in the American journal, is looking into using the low molecular weight heparin in early onset IUGR and the impact on PLGF. And they have shown in certain groups that it could improve fetal growth. But the studies they have done, it is only limited. They published the first series as a case series, and they done a bigger group, which is a paper accepted last month. It has an effect in the singleton. Could we apply that in twins? It hasn't been done. Is there any randomized trial about that? It hasn't been done. So to answer your question, there is only a local case series that is coming only out from John Kingdom in Canada. And the evidence is there is some evidence in certain group of IUGR, it may improve the growth of the baby, but it is like the Viagra we used before, and then when we done the RCT, we found out it doesn't work. So
even
some,
look at
some data suggesting it may work. But if you wanted to use it, you have to use it according to his discussion with him, personal discussion. You have to use it between 16 to 20 weeks to produce an effect. He said after 20 weeks has little effect, but that is in singleton. It's his personal view. Asma.
I think the answer is no to all of them. I think
totally agree.
evidence to give it. I mean, I think, but it is, the truth is that it's, you see many twin have, yeah, they are taking it because for other reasons. So, you know, don't forget a large proportion of twins that result from IVF conception or assisted conception. And certainly I do, to some extent, respect what the IVF doctor or the IVF has, the protocol that they actually prescribe the patient. I know that there's some controversies there, but it's not my area of expertise. And if they have advised a patient to be like with heparin, will not stop it as long as she's not bleeding, for example. And therefore, there will be a proportion of twin pregnancy they are already taking molecular weight heparin because they've been prescribed by their maybe IVF specialist. The other thing is that, of course, twin pregnancy per se or multi-pregnancy is one of the risk factors. So in terms of the risk assessment for venous thromboembolism, there is still this checklist approach, and certainly twin pregnancies or being conceived with assisted conception is one of obviously the risk factors. It depends on how many risk factors she is. There will maybe an indication to be given low molecular weight heparin. But in the context of TTTS or fetal growth restriction, there's no evidence that this is beneficial.
We will agree on that. Thank you very much. Thank you very much, Asma. Thank you very much, Hatem. You've all given us a lot of your input and time. You've been with us online for over the last 2 hours. And thanks for Elizabeth as well for her input. I have to admit, we had over 280 attendees at some point, which is great. Everybody's in summer. So thank you for the attendees. Thank you for the ERC. Thank you very much all for your input. It's been a wonderful webinar, and I'm very grateful for your input and your support. We hope we'll all meet in Cairo in the second half of September. Thank you all and have a great night.
Thank you.
Okay, that's
Thanks.
fine. Okay, thank you, Ahmed, very much for this wonderful meeting. As well, I cannot say anything apart from thanks very much for closest friends. Hatem, he's very close to my heart, and he knows well how much I am appreciating him. And on top, our princess, Asma, she's not very close friend only, but she's very close to everyone. Thank you for your great support, as usual. To be honest, I can tell everyone that Hatem and Asma surprising me all the time by their giving hands and support for everyone, not for the ERC, but for everyone all over the world. If you want anything, even you can phone them anytime, and they're not going to ask you, who are you? Just ask, and the answer will be there. So I'm appreciating their kindness and support and nice communication. Great. Thank you very much for everything. And I think it's one of the fruitful and the successful meeting that I'm appreciating very much. Again, I would like just to announce that we are waiting for all of you, because you are going to meet Hatem and Asma as well, and many other people, and Sharif as well, in our meeting, which will be held in Egypt at the Riyadh Luxury Hotel during the period between 24th and 25th of September. However, the most important thing that I'm advising everyone to participate is their workshop, because it's on top, and we are very happy to participate in this workshop, which is advanced fetal workshop, and as well invasive one, which will start 27th, but invasive procedure. 28th and 29th will be advanced, including Professor Oscar, who is going to conduct sessions or just on-job training or training program on patient for fetal echo. As well, don't forget to participate in the AI webinar, AI workshop, which will be held 12th of September. So I think it will be good. Okay, so thank you very much for everyone. And we are desperate to see you, Hatem and Asma, waiting for both of you and for everyone as well in Egypt. Thank you very much, and have a very nice, sweet night. Thank you.
Thank you.
Bye.
Thank you.
Very much.
Thanks,
Thank
Ahmed,
you.
very much for the effort. Bye.
Thank
See you then. Bye.
Bye-bye.